We're going to be streaming live from Scottsdale, Arizona here at Brio-Medical. Really excited because we're going to be really using all social media platforms here, really integrating on multiple levels, whether that be Instagram, Facebook, TikTok. We're really reaching out to 5,000 plus new faces. So everybody, welcome from around the world or wherever you may be. The power of social media is really something to really get truth out there. And we're going to basically tap into the over 100,000 followers that we have here on all the different platforms to engage with you to talk about all things natural, holistic, and integrative cancer, and really learn the biochemistry and the mechanism of action that defines the human body and the power to really heal. So welcome to our community. I hope everybody's having a great day. Last week I was down in Mexico at a international IPT conference, and so in that conference, we were talking about insulin potentiated therapy. So I thought it would be appropriate to touch on that as it relates to cancer treatment. It was a great conference. And it's great to get together with colleagues really from 4 different continents and talk about IPT. And I think it's important to talk about IPT because IPT is a phrase that I think is misunderstood by most. And the lack of understanding as it relates to these words, I think, impact what people know about it and its potential to help really a lot of people around the world. I love quotes and I love connecting dots. And I love this quote from Seth Godin. Students today are educated in collecting dots, but almost no time is spent teaching the skills to connect. So collect versus connect. You know, it's one thing to just collect dots, to collect information, but it's quite another to connect the dots. And when you look at science, it's not that we have a double-blinded, randomized, placebo-controlled trial that touches on everything. When you look at science, it's really about collecting the data, collecting the dots, and then connecting those dots. When you look at the body is really kind of a 50 billion piece puzzle. And what we are able to do in clinical, laboratory, or imaging, we're able to just really collect a few dots. And the art of medicine, the science is the collecting of those dots. The art of medicine is the connecting of those dots. So really, again, good medicine is a blend of science and art, and it's a blend of collection and connection. And what we're going to do here is connect some dots. So this is that connect the dot thing that was really all the craze when we were kids, which is you have an image there, you have all the dots with the numbers, and you just simply connect the dots. And lo and behold, as you connect the dots, an image starts to appear. So what may look like nothing will actually provide profound image simply by connecting the dots. Otherwise, we look at it, it's just a collection of dots. So when we look at IPT, the meaning of IPT really began in the 1930s. A physician out of Mexico, Dr. Garcia, he coined it insulin potentiated therapy. Actually, that wasn't until the late 70s or 80s that it became that name, but it eventually became insulin potentiated therapy. It was actually initially used to treat neurosyphilis, but then it migrated into the treatment of cancer. Now, more modern day and in cancer treatment with chemotherapy, it's called insulin potentiated low dose chemotherapy because insulin potentiated therapy doesn't equate to always using low dose chemotherapy. So this concept of insulin potentiated therapy and then insulin potentiated low dose chemotherapy in the treatment of cancer really goes back into the mid 20th century. Now, more modern time, conventional medicine in the early 2000s, around 2003, 2004, they came up with a concept of low-dose metronomic chemo. And what I'm going to show you is that these are really one and the same thing. And the quote-unquote alternative or integrative arena brought us insulin potentiated low-dose chemotherapy long before low-dose metronomic chemotherapy ever came on board. So what we want to do is we want to dive into the data. This is a quote from George Orwell from 1984. If thoughts corrupt language, then language can corrupt thought. Now, why would I say such a thing? Well, because when we look at insulin potentiated therapy or low dose or insulin potentiated low-dose metronomic chemotherapy. Conventional medicine, of which I am born out of and trained in, looks at that and basically calls it quote unquote alternative, calls it quackery. In fact, there was a 2019 article that called it quackery, but yet there was a 2019 article in the same year, 2019, obviously, an article that was actually a study that actually showed the science behind how insulin actually potentiates low-dose chemotherapy. So when you can't engage in a debate, you use language to discredit. And that's what happens with things like IPT. But language, so just as thought can corrupt, language, I think, is a more powerful means to corrupt. So let's look at these terms. The term metronomic chemotherapy, again, born out of conventional literature about 2003, 2004, it's currently defined or used for frequent and regular administration of lower doses of chemotherapeutic drugs with minimal drug-free time intervals, or simply lower doses and longer duration of treatment. And this is in order to establish a prolonged and lower active range of plasma concentrations, reducing the side effects. So here's the novel concept, the big picture, if you will. Big dose of chemo, maximum tolerated dose chemotherapy, which is actually developed based on log dosing data, which is actually just from in vitro data, meaning it's not the best of studies. But what they looked at is basically just a 2x4 upside the head. And we know this can kill cancer cells, but we know it can kill a lot of other cells. And again, I've talked about in the literature how it causes cancer to spread. But by lowering the dose, interestingly enough, and giving it more frequently, that metronomic dosing, the anti-cancer effects actually become more broad, yet with less side effects. So low-dose metronomic chemo, again, from the conventional world, can be called fractionated metronomic dosing, low-dose metronomic dosing, insulin-potentiated low-dose chemotherapy that I mentioned. Really, mid-20th century is when that really became a concept, but actually originated in the 1930s. And then we have multiple low-dose chemotherapy. It's in the dosing of about 10 to 30% of the maximum tolerated chemotherapy dosing. So when you look at chemotherapy from a conventional standpoint, it's maximum tolerated dosing. When you look at it from a low-dose metronomic dosing, it's just 10 to 30%. I'll show you at the end how there's actually even some literature that supports even lower dosing. What's interesting is, again, you broaden your anti-cancer effect and you don't destroy that which is good, the immune system, and thus you can actually target the cancer but not destroy the body. And that just seems like a novel concept, but it makes perfect sense. Our goal is to not just target the cancer, but it's also to heal the body at the same time, right? Because, I mean, if we target the cancer, which is wonderful, and we destroy the immune system in the process, what have we done? Well, the literature says we've caused the metastatic spread, or we've set up the stage for that. So looking at fractionated metronomic or low-dose metronomic or insulin-potentiated low-dose chemotherapy, what it's doing is it's actually inducing an immunomodulatory effect. It's modulating the immune system. It's actually stimulating an immunogenic response. Now, this is a new term published in the literature that really is born out of this lower dose of chemotherapy. And this simply means stimulating an immune response. So when you lower the dose of chemotherapy from maximum to low dose, you actually take it from an immune destructive mode to an immune stimulatory or an immunogenic mode. And you go, well, Dr. Goodyear, how could you say that full dose chemotherapy is immunodestructive? Well, they've actually done a study on that where they've looked at T lymphocytes and they've looked at cancer cells to see how quickly recovery in the mitotic phase replication occurs. And when they looked at cancer cells and T cells simultaneously, they found that the cancer cells started to recover at 7 days, whereas the T lymphocytes, which are immune cells, they take as long as 30 days or more to recover. So what happens then is every 3 to 4 weeks with maximum tolerated dose chemotherapy, what you end up getting is you actually end up getting a chronic immunosuppressive state. This leads to immunoinvasion, and that in turn leads to the metastatic risk or local recurrence. So when we look at low-dose metronomic chemo, and again, we'll marry this with the low-dose metronomic chemotherapy, insulin potentiation at the end, let's connect the dots here and let's look at it as it relates to cancer. Because what we want to do here is not speculate. We want to speak data. I always say that. Let's lead with the data. Even if the data is not popular, we must lead with the data. We don't want to set the outcome of the data and then create studies to help us to get that. We want to create studies and follow the data where they go. So here's what we see as it relates to low-dose metronomic chemotherapy and its anti-cancer effects. Number one, it reduces chemo resistance. Two, it reduces cytokine storm. And by the way, I'm going to touch on all of these and provide evidence for them in just a moment as we go through them one by one. Now, cytokine storm is very important because it's associated with how full-dose chemotherapy can actually induce metastasis. This effect is really within the tumor microenvironment. It's immunomodulatory. Now, immunomodulatory can be both immunostimulating or immunosuppressing, so it depends on what effect is occurring. It affects T regulator cells. Now, T regulator cells suppress the immune system, particularly within the tumor microenvironment, and so low-dose metronomic chemotherapy suppresses this. It augments natural killer cells and CD8 cells. These are important immune cells that we need to combat cancer. It stimulates dendritic cell maturation and activity. It can actually be used to augment dendritic cell therapy, which is a conventional immunotherapy. It has immunogenicity. We'll talk about that in just a bit. It induces tumor cell senescence. It induces cancer cell cytotoxicity. It's anti-angiogenic. It reduces vascular endothelial growth factor. It inhibits hypoxia-inducible factor 1 alpha signaling. This is all low-dose metronomic chemo. It stimulates anti-tumor immune effects within the tumor microenvironment. It suppresses myeloid-derived suppressor cells, basically, which are a part of the immunosuppression that occurs. It triggers angiogenic dormancy. It reduces cancer stem cells, very hot topic. It stimulates malignant apoptosis. It restores chemosensitivity and when chemo resistance occurs. And this always blows people away. Reduces the toxicity profile of full-dose chemotherapy. It induces tumor regression, prolongs patient survival. It has similar efficacy compared to conventional maximum tolerated chemotherapy. Now that one really stumps a lot of people, but again, we'll present the evidence. Metastasis, it reduces metastasis. And why is this important? You hear me say it over and over again. 90% of the reason why people succumb to the disease or have morbidity associated with cancer is when it spreads. Another real hot topic is the microbiome. And low-dose metronomic chemo is synergistic with the microbiome, not just the gut microbiome, but yes, there is a tumor microbiome. It enhances the efficacy of immune checkpoint inhibitors. These are many of the more well-known immunotherapies from a conventional standpoint. And it normalizes blood vessel function, which improves tumor perfusion and increases delivery. So let's go through these one by one. So when we look at chemo resistance, we have to recognize that, what is this? Well, chemo resistance is simply a series of effects or phenomenon that renders a cancer cell basically untreatable by a pharmacological treatment. So the treatment doesn't destroy the cancer. It becomes tolerant. There's a lot of different reasons why that occurs. By the way, I mentioned the tumor microbiome, which is a group of bacteria that exist within different types of bacteria. They play a role in that. There are portals that play a role in that. So there's a lot of different things that lead to how cancer cells can become resistant to pharmacological therapy. That could be radiation, that could be chemo, that could be immunotherapy, and yes, that can even be natural therapies. So here we're looking at chemo resistance, and I got a few studies here, so I encourage you to not take my word for this, but actually read this yourself. And so what we're looking at here is 3 studies. You can see 1991, so not new, 2000 and 2016, so kind of spanning the last roughly 30 years or so, looking at chemo resistance and low-dose metronomic chemo. So this is specifically looking at the interaction between the two, not the cause of chemo resistance, but how low-dose metronomic chemo, and again, at the end, I'll tie in insulin potentiation, how it can basically circumvent this resistance. And the first study talks exactly about that, but it's primarily through its effect on angiogenesis. Low-dose metronomic chemotherapy is circumventing acquired resistance. The second study from 2000 shows how in cancer cells, tumors that have become resistant, low-dose metronomic chemotherapy, again, via the same anti-angiogenic effect, it improves the effectiveness of the therapy. So you can actually take a full-dose chemotherapeutic regimen. The cancer cells can become resistant, you can lower the dose, and studies have actually shown you can restore the sensitivity there. And then the last study, the conclusion here from 2016, low-dose metronomic chemotherapy via stromal activation is actually enhancing the treatment response. So its effect here is in what's called the stroma in the tumor microenvironment, and it's actually inducing an anti-cancer effect. Again, when you look at the summary that I just presented with those 27 different mechanisms by which low-dose metronomic chemo has anti-cancer effect, again, lowering the dose massively broadens the anti-cancer effect. So next step, looking at cytokine storm over the last 3 years with the pandemic. I think everybody's heard that phrase at least once, especially the first year or 18 months. Cytokine storm is really just the immune system that becomes overstimulated and unregulated. It's called cytokine storm, cytokine burst, cytokine releasing syndrome. So in the pandemic in SARS-CoV-2, what it did is this virus triggered the immune system in the lung, the pulmonary system, and the immune system became overzealous, overactive, and completely out of control and unregulated, and just started destroying collaterally everything, the lungs included. Sounds kind of like full-dose chemo and healthy cells. But here it's elevated levels of circulating cytokines, which are immune signals, and immune cell hyperactivation that's triggered by many different effects, therapies, pathogens, cancer, autoimmune conditions, monogenic disorders, viruses. So looking at cytokine storm and low-dose metronomic chemotherapy, you get 3 studies here. Looking at the first one, how low-dose metronomic chemotherapy, or this one specifically is describing how chemotherapy induces the metastatic spread. Now, in that article, it's from 2019, they actually talk about ways to counter that. So cytokine storm will induce metastasis, and this always blows people away. When we posted this on social media, I mean, the responses are kind of really interesting, but it's just the literature. It's 2019 article. But in that article, they talk about how low-dose metronomic chemo can actually oppose that cytokine storm-induced metastatic process. Article here from 2016 showing that low-dose metronomic chemo prevents cytokine storm stromal activation. It's a repeat of the other article. This one is just basically saying in the tumor microenvironment, that lower dose, it's not triggering an immune overaction, immune hyperactivation, and it's allowing a anti-cancer effect without basically triggering the immune system that can lead to the cancer and the cancer spread and cancer survival. And then looking at the third study from 2003, so going back in time, they looked at low-dose metronomic chemo versus maximum tolerated dose chemotherapy as having opposite effects by increasing circulating cells. So maximum tolerated dose chemotherapy will increase circulating tumor cells, and that is a component in how the seed and soil theory can take foothold and develop into metastatic spread, whereas low-dose metronomic chemotherapy does not. Again, not my word, just please read the evidence. Next point is looking at immunomodulation. And again, immunomodulatory therapies, this can be natural, this can be holistic, this can be integrative, or this can be conventional. Immunomodulatory therapies modify the responses of the immune system. Again, It can be stimulating of the immune system, or it can be suppressive of the immune system. That's why it's called modulation. It's modulating it. So first article here, looking at how low-dose metronomic chemo has its effect on iNOS, and the impact here was using low-dose cyclophosphamide and showing how it's immunostimulatory. And it's basically because it's countering iNOS. And this is an interesting point because there are a lot of people that take a lot of nitric oxide products, but you have to be really careful because nitric oxide, particularly inducible nitric oxide synthase, can play a role in how cancer can grow and spread. Next article here is looking at the immunomodulatory effect of low-dose metronomic chemo, again with cyclophosphamide, showing how it's regulating the T cell or T regulator cells. That is the immunosuppressive T cell in the tumor microenvironment that allows the cancer to evade the immune system. Low-dose metronomic chemotherapy inhibits that process, and you can see that in the title, an inhibition of CD4 plus 25 plus T regulator cell function. Third article here, looking at low-dose metronomic chemo actually activating the innate immunity. The innate immunity is the kind of hand-to-hand combat that our immune system uses. Think of it as your Army and your Marines. Not necessarily like a laser-guided, Air Force, if you will, jet, really targeting from a long distance, but just storming the beach, hand-to-hand combat, going right at it. And low-dose metronomic chemotherapy activates the innate immunity. And then looking at the 2014 article there, new insights into metronomic chemotherapy induced immunoregulation. So here they're talking about how low-dose metronomic chemotherapy regulates many different parts of the immune system, really which we touched on in point 2 and point 3 here. Suppressing T regulator cells allows the innate immunity to become more active and prevalent. That is in and of itself both immunosuppressive, immunostimulatory, and in a process as a whole, it's immunoregulatory. I've already touched on T regulator cells, but these are a really key component of what happens in and around the tumor and the tumor microenvironment. Recognize that a solid ball of tumors is no longer applicable to just being how cancer exists. It interacts with the body as a whole, particularly in tumor microenvironments. But T regulator cells are cells that are really specialized, and what they do is they suppress the immune response. Now, if you think about it from an autoimmune aspect, that makes perfect sense. You don't want your immune system attacking the body, and thus that maintains a homeostasis and self-tolerance. So your immune system tolerates yourself. But in cancer, cancer is not some foreign body. It's our body, but it takes on these elements and it uses it for its benefit and the body's detriment. So it's not creating new pathways. It's taking normal pathways and adulterating them. So here we're looking at T regulator cells, just a few studies. There's definitely more than this, but I thought I'd highlight just a few. Low-dose metronomic chemotherapy from this 2009 article, different from some of the others that I quoted. It actually suppresses T regulator cells. Now, this is low-dose metronomic temozolomide. And this is a therapy used in glioblastomas. So here, not just using full dose, but they're using a low dose in a rat mouse study. It suppresses the T regulator cells and allows the immune system in an innate and basically hand-to-hand combat actually work. Now, this is just one effect. It's still going to kill the cancer cells, but here it's basically suppressing a part of the immune system that is itself suppressive, and it's allowing the active immune system to elevate. I mean, why isn't everybody doing this? Well, there was a Mexican doctor from the 1930s who started doing it, and it spread throughout the world. And then here, looking at a study from 2007, showing that low-dose metronomic chemotherapy in end-stage cancer patients actually restores T and natural killer cell function through suppression or depletion of T regulator cell. So NK cells and CD8 cells, these are immune cells I talk to a lot of our patients about. NK cells stand for natural killer cells, so their name implies exactly what they do. They naturally kill viruses, bacteria, cancer, all enemies, foreign and domestic. CD8 cells, a little bit more specialized, but they're also known as cytotoxic T lymphocytes, and there are other forms of CD8 cells. But think of these as your Army and your Marines. And what happens when you get an immunosuppressive condition in the tumor microenvironment and around the tumor, such as with T regulator cells that subspecialize, they will suppress the Marines. They will suppress the Army that are here represented with NK cells and CD8 cells. So here's a great quote. Low-dose metronomic cyclophosphamide, a chemotherapy treatment, induces sustained upregulation of tumor-associated CD8 cytotoxic T lymphocytes, natural killer cells, macrophages, and other immune cells to eradicate large established tumors and induce long-term immune memory. Man, I could end right there. I mean, that is powerful. That's a quote from an article which we'll touch on in just a second. But that tells you that when you lower the dose, you don't destroy, you actually establish the immune system to do its job. Let the immune system do its job. Hit the cancer, but don't destroy the immune system. And more than that, induce tumor memory. Get the rest of the immune system involved. So if there's cancer cells floating out there everywhere, the cancer is doing its job as a whole. So this article right here is really more of a summary article looking at the immunogenic cancer cell death. It's describing what they call the key lock or lock key paradigm. And it's describing how the immune system is really immunologically or immunogenically destroying the cancer. They were just in this review article, they go through different mechanisms of how this occurs. And one of the portions of this article describes how low-dose metronomic chemotherapy induces immunogenic cell death. That is, inducing the immune system to kill the cancer cells. Another different article here from 2015, looking at metronomic cyclophosphamide, basically also in a mouse model, in inhibiting glioblastoma cells. And it's doing that through the upregulation of cytotoxic T lymphocytes and natural killer cells, that immune memory. So this is not a one-trick pony that low-dose metronomic chemotherapy here provides. It actually provides this upregulation of cytotoxic T lymphocytes and natural killer cells, but it does so in a way that induces memory. So that it's not just a localized effect, but it becomes a systemic and sustaining effect. Dendritic cells, these are a type of immune cell, a different type. They're what are called antigen-presenting cells. And essentially what they do is they help to involve the adaptive immune system, for the most part, in the immune protection of the body against all enemies, foreign and domestic. They will engulf bacteria, parts of bacteria, viruses, cancer cells, and they will then process that, present to the surface to get the rest of the immune system involved. And low-dose metronomic chemotherapy here with vinblastine actually induces dendritic cell maturation and activation. So it's allowing these antigen-presenting cells to reach full maturity so that they can reach full effect and activation and get the entirety of the immune system involved. Again, not just locally, but also systemically. I'm going through these real fast because I want to make sure that we have time at the end for any questions, but also I want to show you the broad effect here. So this is really kind of a 30,000 foot perspective. So dendritic cells are an immune cell involved in cancer. Low-dose metronomic chemotherapy augments them. Guess what? We have dendritic cell therapy. So from a conventional standpoint, you have dendritic cell therapy. From an integrative standpoint, you have dendritic cell therapy. There's different ways to do this. You can do this autologously. And you can then also do this in a non-specific way. So more of a generated process. There's a product there for prostate cancer that all people with prostate cancer, that is men, can actually receive a dendritic cell therapy. But the autologous, you actually harvest dendritic cells from the individual. You then expose cancer cells from a biopsy to the dendritic cells. The dendritic cells then engulf them, then start to develop an immune response. They then grow them and then give them back to the individual. Dendritic cell therapy is a targeted immunotherapy treatment that involves the extraction, manipulation of dendritic cells to boost the elimination of cancer cells. I really like this article. It's looking at melanoma, metastatic melanoma in people, actual patients, and they treated them with low-dose metronomic chemotherapy, interleukin 10, interleukin 2, and dendritic cell vaccine to really have a profound effect. Now, this was a phase 2 trial, and the low-dose metronomic chemotherapy here was cyclophosphamide. The interleukin 2 was low dose. And so this phase 2 trial was really looking at the efficacy of it, and the efficacy here was actually significant. Again, title of the article, Cancer Immunology. Sorry, it's in the journal, Cancer Immunology and Immunotherapy. So, I think really quick here, when you look at cancer, there's not one thing that causes cancer. Likewise, there's not going to be one thing that treats cancer. It's really the combination, it's the synergism, and it's the sequence of therapies that is going to have the impact of cancer. Going to have the impact on cancer that we all want. Immunogenicity, this is defined as the ability of cells, tissues to provoke an immune response. So again, low-dose metronomic chemotherapy is an immunotherapy. That's what it is. That's what immunogenicity means. So looking at this, low-dose metronomic chemotherapy increases immunogenicity. 2011 article showing that low-dose, non-cytotoxic concentrations in human cancer cells induce an immunologic response. So here, chemotherapy that's normally destructive, it's like carpet bombing, but by using a lower dose and laser targeting it, we do that with insulin potentiation, you actually stimulate the immune system. Here's that lock and key paradigm showing that low-dose metronomic chemotherapy induces immunogenic, so immunologic induced cytotoxicity. That is cancer cell toxicity, not non-cancer cell cytotoxicity. Now, senescence, this is a complicated topic here, but I'll touch on it really quick and briefly. It's the defense mechanism involved here that switches a highly proliferative or pro-growth cell or groups of cells to a stable, non-proliferative, but still metabolically active survival state. And the induction of this senescence actually results in a stable cell cycle arrest. Thus, this serves as a defense mechanism against cancer. So really what this is if you go back to, junior high biology, talked about the interphase and mitosis phase. The interphase was that G0, G1, S, and G2 phase, where the cell is basically getting ready to then go into mitosis and go from one cell to two. And the G0 is the dormancy phase. So basically what you're doing here with low-dose metronomic chemo, that is the concept of senescence, you're actually, through this lower non-lethal dose, you're actually causing this pro-growth process to basically stop. So get this quote. Senescence at non-lethal doses, that means non-lethal chemotherapy, induces senescence in a cytostatic clinical response, but some of these therapy-induced senescent cells may reactivate and lead to recurrence, but they may also be an opportunity for tumor targeting to enhance cell killing. So it's better to have cancer cells that are in cell cycle arrest than those that are growing rapidly. So low-dose metronomic chemotherapy can actually induce this quiescent or senescent state and thus allow you to come after it and kill it even more. So here we're looking at senescence and low-dose metronomic chemotherapy. The first article from 2005, neoplasia, low-dose metronomic chemotherapy induced senescence gene activation. Then showing in the second one how low-dose metronomic chemo triggers a senescent cell state in human cancer cells. Now understand that senescence can be bad too, because if you have an immune cell that becomes senescent, then it's not going to be active. So here we're talking specifically about its effect on cancer cells. Third article, low-dose metronomic chemo with navalabine and 5-FU provides significant increase in cancer cell senescence in neuroblastoma cells. And the last one showing how it's just a review article showing how this senescence by chemotherapy is actually inhibiting relapse. So cytotoxicity, that's really just two words, cytotoxicity, cyto being cell, toxicity being toxicity, obviously. And so this is chemotherapeutic drugs or therapies that rapidly kill dividing tumor cells. These are generally toxicity to rapidly dividing cells. So that's where we get the cytotoxicity. And really, this is any exogenous substance that is toxic to these rapidly dividing cells. So that can be chemo, that can be radiation, that can be natural therapies as well. Vitamin C in high doses and therapeutic doses cytotoxic also. Interestingly enough, the first PubMed reference to cytotoxicity was back in 1954. So, these concepts are not new. Now, how is it doing it? How is low-dose metronomic chemotherapy impacting cytotoxicity? Well, here, first article showing it's doing it through its anti-angiogenic effect. We'll talk about that in just a second, but that's from 2000. The other article is showing how, from 2000, continuous low-dose metronomic chemotherapy induces cytotoxicity of cancer cells without overt toxicity in non-cancer cells. Kind of a novel concept. Kill cancer cells, but not the healthy cells. That should be our target. That should be our aim. That should be our goal. And until we achieve that, we should always seek to achieve that. Here we're looking at angiogenesis. And actually, angiogenesis, it's the process of new capillary blood vessel growth with or out of pre-existing blood vessels in the body. This is critical to cancer. Cancer has a very, very high metabolic demand. And to meet that high metabolic demand, it needs a lot of supply. It needs a lot of supply, a vascular supply. So it stimulates the processes of angiogenesis. And in fact, early on, low-dose metronomic chemotherapy was thought to be primarily an anti-angiogenic effect. There's many different types of this neovascularization process called sprouting angiogenesis and tussoceptive angiogenesis, vessel splitting, vasculogenic memory. I mean, just all kinds of different names and processes involved here. But when you look at low-dose metronomic chemotherapy, its effects are broad. Here showing low-dose metronomic chemotherapy induces an anti-angiogenic effect, a 2002 study looking at chemotherapy via low-dose delivery. Next one showing low dose at ultra low concentrations of paclitaxel, ultra low dose. Now, we're not talking low dose, ultra low dose. So I'm waiting for ultra low dose. Haven't gotten there yet in the literature. But this inhibits angiogenesis. So if you inhibit angiogenesis, you are turning off the vascular supply. You are turning off the feeding of a growing tumor. It cannot meet its metabolic demand, and it will slow its metabolic rate or even die. And then the third article, low-dose metronomic chemotherapy is anti-angiogenic. And it's basically the basis of low-dose metronomic chemotherapy. Now, vascular endothelial growth factor is a part of the process of angiogenesis. It's vascular, it's endothelial, and it's stimulating growth. It's a potent angiogenic factor. It was first described as an essential growth factor for vascular endothelial cell growth. It's upregulated, no surprise, in many tumors, and it contributes to this process of tumor angiogenesis. So though these are clearly connected, they are independent. These vascular endothelial growth cells are expressed in tumor cells, macrophages, platelets. Platelets play a critical role in angiogenesis, but also in metastasis. So here are just a few articles. Low-dose metronomic Taxol chemotherapy inhibits vascular endothelial growth factor through anti-angiogenesis. So the vascular endothelial growth factor stimulates angiogenesis, but the low-dose metronomic chemotherapy with Taxol inhibits the process. Next article, a combination, as I mentioned before, it's better to do these together. Now, this is looking at relapsed or refractory non-Hodgkin's lymphoma patients, and they use Cytoxan and etoposide plus prednisone, and this inhibit vascular endothelial growth factor, and this improved the response rates and the progression-free survival. There's no the term cure is not clinically, it's not a clinically validated endpoint. So that term can't be used from a scientific perspective, but survival can. And so there's different phases of that survival: overall survival, progression-free survival. So these are clinical endpoints that we can actually say there's science behind them. So I think when anybody's saying, well, this therapy will cure you, that is not a scientific statement. But if you say studies have shown this will prolong your overall survival, that is something science can stand behind. And that's what we want, right? Overall survival. We just want that overall survival to be, what, 5 decades. We don't want it to be just 5 years, let alone 5 months. And then this last article, a systemic review of all the literature, 2019, Journal of Oncology, looking at low-dose metronomic chemotherapy inhibiting vascular endothelial growth factor. Hypoxia-inducible factor 1 alpha. This is a protein complex that plays an integral role in the body's response to low oxygen concentrations, or what's also known as hypoxia. A lot of people talk about this as it relates to cancer, thinking that the entire tumor and the surrounding tissue is hypoxic or low oxygen, and that's just not the case. Once the body becomes totally hypoxic, then the body succumbs to the disease. But here we're talking about pockets within the tumor. There's actually normal oxygen areas within the tumor, but in those hypoxic areas, this factor, this protein complex, is upregulated. And guess what? Low-dose metronomic chemo targets and inhibits this hypoxia-inducible factor 1 alpha in hypoxic regions. This is critical. If you check out some of the previous webinars where I talked about iron and the immune system in the tumor microenvironment, this hypoxia actually, it aids how these macrophages that get recruited into the tumor microenvironment, how they dump their iron into the tumor microenvironment, into the tumor in these hypoxic regions, and that enables cancer cells to take that iron up and use to grow. Second one, showing how metronomic chemotherapy actually offsets, so they were using an alternating, whereas maximum tolerated dose chemotherapy was inducing hypoxia-inducible factor 1 alpha. That is correct. You heard me right. Maximum tolerated dosing chemotherapy was inducing this hypoxia-inducible factor 1 alpha activation, but yet using low-dose metronomic chemotherapy countered it because it was inhibiting the hypoxia-inducible factor 1 alpha signaling. So in a way, you could say that maximum tolerated dosing of chemotherapy induces hypoxia. And that is true. And that is one of the mechanisms by which it causes metastatic spread. But again, the low dosing will counteract that. And then the third article, looking at low-dose metronomic chemotherapy with doxorubicin, it inhibits the protein complex activity that we mentioned. Tumor microenvironment, we could talk forever about. This is really a fascinating arena of our understanding. No longer can cancer cells or tumors be seen as isolated and separate from the body. They interact with their environment. That is the tumor microenvironment. It's a microenvironment within or of the tumor that's a set of a lot of cellular and molecular components, and these form the tumor and tumor environment, and it basically helps to initiate it, to grow it, to protect it, and eventually send it throughout the rest of the body. So when we look at low-dose metronomic chemotherapy in the tumor microenvironment, this is critical because it is really this environment and the cells within it and the adulteration of that environment by the cancer that allows the cancer to evade this localized effect and leave and go to the rest of the body. And that in turn is where the metastatic spread of cancer occurs. The first article looking at lung cancer growth, showing that low-dose metronomic chemotherapy with paclitaxel modulates the tumor microenvironment in a anti-metastatic way. And this is low-dose paclitaxel, and it's using it in conjunction with a dendritic cell vaccine. Number 2 here, looking at low-dose metronomic chemotherapy, down-regulating what's called transforming growth factor beta. So this is another immune signal within the tumor microenvironment that suppresses the immunity. Low-dose metronomic chemotherapy down-regulates that immunosuppressive in the tumor microenvironment, it allows the immune system then to invade and have its anti-cancer effect. That's with cyclophosphamide. Don't ever let anybody say there's no evidence to support low-dose metronomic chemotherapy, and I would say with insulin potentiation. Low-dose metronomic chemotherapy via this third study actually normalizes the tumor microenvironment. That tumor microenvironment is where so many healthy cells exist, yet they are alternated, they are adulterated, they are converted to really become kind of a double agent. Instead of helping the body, they help the cancer against the body. So they become the immune system there becomes like a Trojan horse. Interestingly enough, the cancer cells, the tumors, will recruit the immune cells to the tumor microenvironment and then mutate or turn the immune system on the immune system. So in many ways, it's autoimmune-esque. Myeloid-derived suppressor cells are a type of immune cell recruited to the tumor microenvironment, and they are pathologically activated neutrophils and monocytes, and they have very, very immunosuppressive activity. So I already talked about T regulator cells, talked about transforming growth factor beta. Here I'm talking about myeloid-derived suppressor cells. So looking at low-dose metronomic chemo with 5-fluorouracil induces T-cell dependent myeloid-derived suppressor cytotoxicity. So it's actually suppressing the myeloid-derived suppressor cells, allowing anti-tumor T-cell dependent immunity to actually do its effect, which is kill cancer cells. Whereas myeloid-derived suppressor cells would normally downregulate that. Here, low-dose metronomic chemotherapy counters that and allows the immune system to do its job. Dormancy, a very simple concept here, classically defined as arrest of tumor growth. This is more of a permanent state rather than that senescent state. And this can be in the primary site or the metastatic site. Important to touch on right here, we had a question on social media when I was down in Mexico that I answered. I don't know if that's posted yet, but the question was, they said, well, no, you don't treat cancer until you see it. No, you want to treat cancer before you see it. Our understanding of how cancer spreads now is that as soon as cancer exists and it's invading and growing, it is spreading. So our understanding of the process of cancer, thankfully, is improving. Thus, science is always changing. If you say trust the science, and thus you don't question the science, that by its nature is unscientific. So we're here talking about tumor dormancy, tumor mass dormancy, and cellular dormancy. And this is really that G0 phase where the cell just goes into a perpetual state of rest and it's dormant. Here, looking at a 2000 article, again, 23, almost 25 years ago, quarter of a century, continuous low-dose therapy with vinblastine and VEGF receptor 2 antibodies, so a combinatory therapy, induces tumor regression without overt cytotoxicity. And what it's doing here was inducing tumor dormancy. Now, we want tumor elimination, but if you allow a treatment that induces tumor dormancy, then other treatments can come on board and eliminate the tumor that is dormant. Cancer stem cells, these are the backup copies that we want no part of. Everybody has a backup of their phone, but the problem is when cancer cells have backups, that's something we don't want to upload. So here it's a small subpopulation of cells within tumors with the capability of self-renewal, differentiation, and tumor genicity. They're typically resistant to conventional chemotherapy, and they in fact play a key role in resistance, but also a key role in the metastasis of cancer. So here, low-dose metronomic chemotherapy, reducing cancer stem cell number, 2007 article, doing it primarily through anti-angiogenic effect and cytotoxic effects of a glioblastoma tumor model. And the 2013 article here showing how alternating the low-dose metronomic chemotherapy with maximum tolerated dose chemotherapy inhibits cancer stem cells. Now, at the very end, I'll close with a quote actually showing how actually alternating these therapies is not advisable because the maximum tolerated dosing can actually stimulate cancer stem cells. Apoptosis, this is programmed cell death as it's more known. Think of it as an orchestrated collapse of the cell, and this leads to its death. It's known more in a general term of programmed cell death. And guess what? Low-dose metronomic chemotherapy, in line with the theme, promotes malignant apoptosis. Here, a 2012 article from actually Indian Journal of Pediatrics from the country of India. Basically, what they're doing is they're just looking at basically old drugs in a new package, as the title says, and they're just saying, hey, we're just going to take low-dose chemotherapy. So take this old package, that is chemotherapy, lower the dose, we repackage it, and guess what? We got a new therapy that doesn't destroy the body, but actually heals the body. It destroys the cancer cells too. And then the next article from 2014, metronomic chemotherapy, showing that low-dose metronomic chemotherapy triggers malignant apoptosis again. Chemosensitivity, this is simply the susceptibility of tumor cells to the cell-killing effects of whatever treatment that's being employed. Here we're talking about chemotherapy. Obviously, a lot of people that present to us and to many doctors taking care of cancer is they've already undergone full-dose chemotherapy or radiation or surgery, and these types of therapy modalities given over months after months after months induce chemoresistance. So what we must do is restore chemosensitivity. And lo and behold, here's a 1991 article showing how low-dose metronomic chemotherapy restores chemosensitivity through the mechanisms of its anti-angiogenic effect. I already touched on this article earlier, but this is how people come in, and research has showed they can be resistant to chemotherapy. But if you lower the dose, you actually change the effect of the chemotherapy, and you actually can restore chemosensitivity. Now, you can combine it with other therapies, and that'll help it even more. 2013, low-dose metronomic chemotherapy is a chemosensitizing therapy. And then 2013, showing how they're combining low-dose oral cyclophosphamide in platinum-resistant recurrent ovarian cancer cases with a monoclonal antibody. And this was in turn restoring the chemosensitivity in what was a prior resistant situation. So even though resistance may exist, sensitivity can be restored if properly treated. Toxicity, I think, is pretty self-explanatory. It is a substance that is a toxin or poison that can harm animals. And this is interesting because harm humans or animals, and the amount or degree of the substance needed to be poisonous. So everybody looks at chemotherapy, and correctly so. It is a toxin. It is a poison. Now, that's at full dose. And I've often said that, chemotherapy is a treatment of cancer born out of war, and thus it goes to war on the body and it becomes a toxin and a poison. You check out the podcast at the Practicing with Dr. Nathan Goodyear. It hasn't posted yet, but it will be. I describe the process by which chemotherapy became known out of war to then become a part of the declaration of war in 1971 that has been a part of the process of war since. And then what has been basically the collateral damage that had resulted from that. But when you take that toxin and then you lower the dose, in many ways, it's no longer a toxin, interestingly enough. So it reduces toxicity. Low-dose metronomic chemotherapy lowers the toxicity and adverse effects compared to maximum tolerated dose chemotherapy. And this is with cisplatin in chemoradiation, local, regional, and nasopharyngeal head and neck cancers. Second article from 2012 showing that low-dose metronomic chemotherapy decreases adverse events in advanced cancer patients. So again, these are the worst of the worst. These are studies that were designed to not succeed. They're picking the worst, more of what you might call a selection bias. They're picking patients that are advanced and not doing well at all, and they need treatment. And low-dose metronomic chemotherapy comes in and provides treatment. Then a 2013 article really during showing how low-dose metronomic chemotherapy can be used in low-income and middle-income countries where cost is a concern. So it provides low toxicity but viable, effective treatment in a need where cost is a big concern. Tumor regression is also pretty self-explanatory. It's a decrease in the size of the tumor burden, or the extent of the cancer throughout the body. And looking at low-dose metronomic chemotherapy, it slows tumor growth through the promotion of tumor regression. Prolonged patient survival. I mean, that is kind of what we're all after here, right? We want our patients, we want our loved ones, we want ourselves to survive and live longer. And of course, this is defined as the length of time from either the date of diagnosis or the start of the treatment for the disease. In this case, we're talking about cancer. Looking at prolonged patient survival, first article here, 2009, showing metronomic oral navalabine or veneralabine in advanced refractory cancer. Again, selection bias again. These patients are not doing well. They're the worst of the worst. Studies designed to fail, right? They're showing that low-dose metronomic chemotherapy can actually prolong patient survival here. Now listen to this. Objective anti-tumor response was seen, documented in 8 cases, or 32% of patients. They experience stability of disease for 6 months. Now, we want more than that, but this is a group of patients that were basically leaning over the edge, holding on with a thread. And low-dose metronomic chemotherapy provides 6 months of stable disease. And they had 3 patients that underwent nonstop treatment for over 3 years without any overt toxicity. 3 years in advanced refractory cancer, that's pretty darn good. Low-dose metronomic chemo prolonged patient survival in palliative cases. This was a case study of ovarian cancer with low-dose metronomic cyclophosphamide in a palliative case, meaning just really providing comfort more than anything. And they were able to provide prolonged patient survival. Now, we want that without disease, but sometimes the first step to eradicate disease is to stabilize the disease. Low-dose metronomic chemo is equally effective compared to maximum tolerated dose chemotherapy. Now, that may sound controversial, but again, we don't want to just make a statement or opinion. We want to follow the science. So we want the intended effect here. So here we're looking at an article from National Review of Cancer. Less is more. Low-dose metronomic chemotherapy maintains comparable efficacy or effectiveness compared to maximum tolerated dose chemotherapy. So that's actually a government sponsored and funded study actually showing that. Well, actually a review article there. Here, looking at metastatic breast cancer, low-dose metronomic chemotherapy equally effective compared to maximum tolerated dosing standard of care treatment in metastatic breast cancer. Wow. I'll give you a quote from this article at the end. This was from 2006. Also showing similar efficacy of low-dose metronomic chemotherapy compared to conventional cancer treatment in the treatment of metastatic breast cancer. So here we're seeing 2 articles saying the same thing. Metastatic breast cancer, which unfortunately we're seeing way too much of that today. Way too much of that. Pre-COVID cancer was one thing, post-COVID it's something completely different. Looking at low-dose metronomic chemotherapy, it is equally effective to metastatic breast cancer as conventional cancer treatment, yet without the toxicity. Metastasis, 90% of morbidity and mortality is a result of metastatic spread of cancer. And yes, low-dose metronomic chemotherapy inhibits the metastatic spread of cancer. The first one looking at a pancreatic cancer model. Second, looking at low-dose metronomic chemo inducing a less metastatic favorable tumor microenvironment. One of the effects of what full-dose chemo or maximum tolerated dosing chemotherapy is doing is it's really creating a storm, if you will, within the tumor microenvironment, and it's within this construct that the stroma and the matrix alters and changes so as to allow the cancer to grow, evade, and spread. And then the last one, low-dose metronomic chemotherapy did not stimulate tumor or metastatic favorable stromal response compared to full-dose chemo. So again, looking at the impact, still target the tumor, but not the body, and not to target the spread of the cancer. Microbiome, most know the microbiome as it relates to the gut. This is just the collection of bacteria, fungi, protists, archaea, viruses that occur in and around the human gut. It's collectively called the tumor microbiome. It broadly refers to all more organisms, though, located within the tumor microenvironment, and this even includes within the cancer cells. And as I mentioned earlier, yes, there is a tumor microbiome. Now, our understanding of this is very limited because this is very recent, but this process also, we know, plays a role in the resistance of cancer cells, that is the tumor microbiome. But here we're talking mostly about the gut microbiome. And what do we know about low-dose metronomic chemotherapy and the gut microbiome? It's immunomodulatory. Everybody talks about how the gut microbiome plays a key component in the immune system, and combining low-dose metronomic chemotherapy with that, it's immunomodulatory. We also know that low-dose metronomic chemotherapy versus maximum tolerated dose chemotherapy, they impact the gut microbiome differently. The gut bacteria in patients in low dose versus maximum have different types of bacteria. And this affects the immune system and plays a role in the ability of cancer cell to evade, survive, and thrive, both locally and distantly. And then the last article really is talking about the intratumor microbiome, not from a low-dose metronomic chemotherapy, but a microbiome is a microbiome is a microbiome, right? So if we can induce a change in the microbiome in the gut and make that immunomodulatory, then we should be able to induce the same in the tumor microbiome. Maybe that's why in chemo-resistant cancer cells, lowering the dose in a low-dose metronomic chemotherapy could actually restore sensitivity early on. Immune checkpoint inhibitors, these are some of the well-known immunotherapeutics we know today. These are inhibitory regulators of the immune system that are crucial to maintaining self-tolerance so as to preventing the immune system from attacking itself. Tons of articles here, but just a few showing how low-dose metronomic chemotherapy is synergistic with these immune checkpoint inhibitors, improving the efficacy of the immune checkpoint inhibitors in squamous cell lung carcinoma, synergistic with anti-cancer immune effects with the immune checkpoint inhibitors in this 2017 study looking at a combination of the two and targeting therapy-resistant cancer cells. And then I love this one from Journal of Immunotherapy and Cancer from 2020, so very recent, showing how they're not just synergistic, that is the immune checkpoint inhibitors and low-dose metronomic chemotherapy, but they're actually additive. So they're synergistic, but they're additive. So the two is better than the one. Survival. We talked about prolonged survival. Here we're just simply talking about survival. And so, article from 2014 showing increased long-term survival with low-dose metronomic chemotherapy. And in this first study, it was defined as greater than 50 months. So obviously we want 50 months to be, 500 months. Not sure how quite long that is, but we're talking about a long time. And so this study, they defined long-term survival is greater than 50 months, and low-dose metronomic chemo actually provide that in metastatic breast cancer. That's profound when you think about that, because metastatic breast cancer is a degree of cancer that is very difficult to treat. We just have a patient right now. Bone mets have resolved, and most would approach that and say once you develop bone mets, that is something that they would say is quote unquote non-curable. But I've seen it time and time again where it is. eliminatable. I don't want to use that word cure, but it is, you are able to eliminate any evidence of those bone mets. And then the other one looking at low-dose metronomic chemo alone, get this, it outperformed the combination of low-dose metronomic chemotherapy with a well-known targeted agent, thalidomide, in long-term survival, here defined as greater than 24 weeks. So here, low-dose metronomic chemotherapy actually outperformed the combination of this targeted drug with low-dose metronomic chemotherapy. And I'm going to end with cancer-associated fibroblasts because I am a nerd and a geek. Cancer-associated fibroblasts are cells within the tumor microenvironment. Fibroblasts are normal cells. They are not themselves bad, but what happens in the tumor microenvironment is the cancer cells adulterate them. They turn them on the body. And here, these fibroblasts, there actually are what are called normal associated fibroblasts. They become shifted and they turn to become cancer-associated fibroblasts. And this plays a key component in the tumor microenvironment and allowing a pro-tumorigenic environment to occur. And looking at low-dose metronomic chemotherapy, first here I want to touch on showing that the cancer-associated fibroblasts really from a mechanism regulate the tumor occurrence, development, the metastasis, and the resistance to treatment. But this 2019 article looks at how this how the cancer-associated fibroblasts promote the dissemination, so the release and the resistance to therapy. So cancer-associated fibroblasts are key in the immunosuppression in the tumor microenvironment, but they allow the cancer to grow and spread, survive, and thrive. And the last article shows that low-dose 5-FU reverses the multi-drug resistant therapy, multi-drug resistance induced by cancer-associated fibroblasts by eliminating the cancer-associated fibroblasts. So the first two articles here, I'm touching on how cancer-associated fibroblasts are really promoting cancer growth, survival, and spread. And then I'm providing the 2017 article, how 5-FU actually counters all of it by eliminating the cancer-associated fibroblasts. And this quote, I think, kind of sums it up. The traditional maximum tolerated dose chemotherapy regimen has been reported to induce cancer-associated fibroblast secretion of chemokines that endow tumor cells with cancer stem cell traits, ultimately fostering chemoresistance, I would say spread. In contrast, metronomic, also low-dose metronomic chemotherapy, consists in administering low doses of drug on a more frequent or continuous scheduling, preventing the cancer-associated fibroblast paracrine signaling and resulting in enhanced treatment response. Now, low-dose metronomic chemotherapy did not exist until roughly 2003, 2004 as a phrase. But insulin-potentiated low-dose metronomic chemotherapy did exist starting back in the 50s and 60s. So this concept is not new, just conventional is taking it on for itself. So as I mentioned early on, low dose is not enough. There's actually ultra-low dose chemotherapy. Now, low-dose metronomic chemotherapy, whether that's with or without insulin potentiation, is typically defined as between 10 and 30%. So ultra-low dose is going to be less than 10%. And here, it stimulates goodness gracious. It stimulates chemoimmunomodulation of the immune effector cells to target cancer cells. So what this is actually doing is stimulating the immune system to do its job, not destroy it, but aiding the immune system to do its job. So using fractionated metronomic, low-dose metronomic chemotherapy, or with insulin potentiation, actually is shown to provide disease control in advanced refractory cases, including metastatic breast cancer, and providing so with lower adverse events compared to maximum tolerated chemotherapy, and doing so in prolonged survival. So when we look at these terms, again, insulin-potentiated therapy really began in the 1930s. It migrated to the use in treatment of cancer in the 1940s, and then throughout the rest of the 20th century. It became known and combined with chemotherapy as insulin potentiated low dose chemotherapy, IPT-LD. 2003, 2004, low dose metronomic chemotherapy came in. It's really the same thing as low dose potentiated chemotherapy with insulin. They're really one and the same. The big difference, though, is insulin. So when we look at these terms, what we end up really coming to is when you look at low dose metronomic chemotherapy and you contrast that with IPT, really what we have with IPT is low dose metronomic chemotherapy with insulin potentiation. And I can touch on this on a future webinar and a podcast where a 2019 article showed how insulin at the right dose, the low dose, actually downregulates the pro-growth genomic pathways that cancer takes on. Not that insulin promotes growth, but actually that it downregulates the growth, but also increases the permeability of the cancer cells to treatment. That is a 2019 article. So what we've done is collect the dots and connected the dots. And this is that 2019 article showing how insulin enhancement of anti-tumor activity of chemotherapeutic agents in colorectal cancer is linked with downregulation of the P13K and GRB2 pathways. So this is the science. May not be science people familiar with, but it's still there. Just because you don't see gravity doesn't mean it doesn't exist. Try jumping off the second floor. Just because we don't know the science doesn't mean it's not there. We must first look, then we must read. Then that is simply the collection of the dots. Then we must connect the dots. And that's what we've done here. So a little deep, a little long, but because of the questions we get in the things we put on Instagram, the Instagram account, Dr.Goodyear, on website, www.drgoodyear.com, and then Practicing with Dr. Goodyear podcast, as well as LinkedIn and wherever you may find us, we get a lot of questions that say, there's no science behind this. So what I wanted to do is just throw it right in there and say, there's the science. Please read it and learn. So now let's open it up for some questions. I'm the medical director at Brio-Medical. When I get into these, I get into just talking about all the evidence, start geeking out. But I'm the medical director at Brio-Medical. You can find us over at brio-medical.com. You can find us on all the social media websites as well, Instagram, Facebook, LinkedIn, even TikTok. We do post every day, sometimes more than one time a day. So check that out there, because that's where we try to engage you to heal and teach you how to heal yourself. I've done a lot of IPT, but it took a while to find the exact right chemo for me. They're asking about a test. I won't mention the name of the test, but it's a test that's advocated to determine the sensitivity. I'm happy to say I'm 98% healed from my cancer, my 7th year of seeking solutions. Well, first, Marie, congratulations. The job of a physician, the word in Hebrew, Rophe, it actually means healer. I'm thrilled for you. There's no greater day as a physician than when we get to sit with a patient and show them that however we look, there's nothing. And this patient I mentioned that had the resolution of bone metastasis, she had this huge 9 by 10 centimeter mass in her right breast when she came in. And so I was re-examining her, and I was like, I know, I told her I don't feel anything. She said, I know. So it's just, and she just started crying. So the looks on that, it's just congratulations. There are a lot of different ways that you can test for this in terms of sensitivity. I think some of the reliability of some of these studies are somewhat suspect. Again, when you look at these studies that I presented, they're not looking at sensitivity. They're not saying that we did tests here that shows that this drug is better over this drug. We're simply describing the mechanism of action. By lowering the dose from just a 2x4 beside the head, it becomes a very targeted, very broad anti-cancer effect, irregardless of whether that had been tested to be responsive to the chemo at all. So healing is a journey, okay? So healed, Recognize you need to heal every day. So you continue your healing journey. Congratulations to you. Can we get a link to the recording? Yes, we will have that coming tomorrow on the Brio. It'll be in the newsletter. Okay, be in the newsletter. So look for that. Go to the Brio-Medical website to sign up for the newsletter. Yep. So www.brio-medical.com. Yeah, I encourage you to share this with your doctor. That's why I lead with the science. I love my profession. I love taking care of patients. I do think that medicine as a whole has lost its way a little bit. That doesn't mean that doctors are not doing their best. It's just we need to recognize that we need to serve our patients first. Let's see. So after chemo, can you guys do checks on our whole body and try to find the root cause, or we have to do it prior to chemo? Yeah, that's a great question. When patients come in with stage 4 advanced, often recurrent because they've received multiple conventional rounds of chemo, radiation, etc., there's a time and the place for determining the root cause. When a patient is on the edge, that's not the time to extract all the teeth in your mouth. Now, might there be bad root canals there? Might there be infections there? You bet. You bet. But is that the time where a patient is already cachectic, not able to eat, not able to gain weight, sitting at about 90 pounds? Is that the time to take teeth out, looking for the root cause? No. You've got to allow that patient to recover somewhat. You've got to treat the cancer that is basically degrading them. And then once you're targeting the tumor, healing the body, then as a person starts to get stronger, you pull them out of that tailspin, then you can actually start to look at those root causes. So you can actually start doing that in the midst of treatment. That's what we do here is we're going to assess and see where that individual is when they first come to us at Brio-Medical. But then what we're going to do is we institute treatment. Once we start to see a person that is stronger, getting stronger and responding, then we know we can go ahead and start to do some different turns in trying to identify root causes and then to provide treatment. But if we say, well, let's take out all these bad root canals, don't get any treatment in, and then a patient with metastatic cancer then succumbs to their disease before you get any treatment in because you spent all your time taking out the teeth. Again, not saying that sometimes is not needed. Bad root canals are bad root canals. That's why it sounds like I'm whistling through my teeth here. I got a retainer with a partial tooth in because I had a tooth extraction because it was a bad root canal when I was playing football back in my 20s. Yes, I know root canals are not what we want, but I was 20 and didn't know much. So, and I did what my coach told me to do. But anyways, so it's all about the right time. It's all about the right timing. So I was given Taxol on my IPT, but had a horrible adverse effect. The one chemo that worked all by itself was in her too. Yeah, so just because it's lower dose doesn't take away the possibility that it's toxic. And remember, IPT is not defined by dose. It could have been 30% low dose chemo with insulin potentiation. It could have been 10%. We don't know. So, and often too, when you look at these protocols of IPT, there can be other things that are added to it in terms of other drugs, other therapies. That's what we do here at Brio. We combine it with photodynamic therapy, medical cannabis, particularly cannabinoids. You can add in other things like curcumin, DCA, that even improve the sensitivity further. Also, too, recognize, sometimes an adverse effect could be a massive die-off. So you have to really look at the individual, recognize that even though it's low dose, it still can have adverse effects. I tell patients all the time, natural, holistic, and integrative by no means easy, and by no means means without side effects. So good point there. Have you treated pancreatic cancer? Yeah, unfortunately, we see way too much of that today. What are the options if it's spread to the liver, if chemo stopped working? Again, in this presentation, okay, I actually talked about restoring chemosensitivity in patients with chemo-resistant cancer. Lowering the dose of chemotherapy has been shown to restore chemosensitivity. Now, you don't want to just rely on that move alone. You want to combine it, synergize it, and sequence it with other therapies. So DCA is a great opportunity to sequenize these. It's a glycolytic inhibitor, melatonin, CBD, photodynamic therapy, curcumin, even vitamin C. All of these therapies can improve the sensitivity of the cancer to the chemotherapeutic agent, even at lower doses. Another person asking about a sensitivity test from a particular company. I'm not going to call any company out by name. What we do is to be very specific and targeted in our approach to cancer treatment. We will do testing of the tumor, and we will look at that via genomics. We also have the ability through some of our peptide partners to do proteomic testing, that's proteins, transcriptomic testing. This is with Neo7 Biosciences, but then also metabolomic testing. And we use that plus the genomic testing from the tumor, the blood, the urine, and this allows us to be very specific and targeted. So when we look at it, with the test you're referring to there, it's an anonymous. It's looking at it from really kind of an antibiotic perspective. There's infection, you have a bacteria, so let's find the right agent to attack that with the sensitivity. Cancer is a lot more complex than that. Now, I think that can be definitely helpful. There's no doubt about that. But the concept of cancer is bringing together genomics, epigenomics, transcriptomics, proteomics, metabolomics, immunomodulomics, and whatever omics. But the point here is it's a lot more complex. And I think just looking at cancer treatment through that simple prism of sensitivity, though it may be helpful, I think it's missing a broader picture that we need to really focus on. So we do targeted testing. We try to, though, bring in the science into what we're doing there. Somebody asking about relapsed Hodgkin's lymphoma. Again, there's lots of ways that you can approach this. So you have to look at it from, okay, so Hodgkin's lymphoma classic treatment is typically R-CHOP or other things. So they're chemo agents, ABVD, so they're chemo agents. So full dose, maximum tolerated, 2x4 upside the head. So then what happens, you get resistance that develops. Again, in this lecture, podcast, webinar, I've been able to show you how lowering the dose can restore the sensitivity of the cancer cells to the chemo agents. Now, you would want to do more things, but simply lowering the dose in low-dose metronomic chemotherapy, and here what I would say is potentiated with insulin, it allows you to take a recurrent relapse situation and actually restore the sensitivity. So I would tell you there's always hope. So good luck to you, because you can actually treat relapsed Hodgkin's lymphoma. Is this effective for late-stage prostate cancer with mets to bone? Sue, great question. When you look at prostate cancer and breast cancer, they're really one and the same, kind of. I mean, obviously prostate cancer is in men and breast is in women, but I've seen 4 breast cancers in the last 3 years in men. Very rare, but when you look at the behavior of prostate cancer and breast cancer, there's many similarities. So yes, we have a patient here recently, bone mets resolved, breast cancer, prostate cancer, recurrent prostate cancer, breast from many years, prior treatment, now no evidence of bone mets. And guess what? His treatment, Sue, completely natural. He didn't want to do anything integrative. No medications, just completely natural. Just talked to him today. Was up in the Northeast. So, so it's super excited to see that. And I just mentioned the breast cancer patient with bone mets too. So yes, it absolutely is effective. And as I mentioned in a couple of those studies, they talked about specifically the use of low-dose metronomic chemotherapy being equally effective as maximum to tolerated dose conventional cancer treatment from a chemotherapeutic perspective in metastatic breast cancer. And I would put prostate cancer kind of right there in that same uh, picture of how they behave. Let's see. Does the COVID vaccine shedding infection have an impact on the success of IPT? That hasn't been studied, but here's what I would say on this. I'm presenting in April on the topic at the FLCCC conference in Dallas. The literature on SARS-CoV-2 is that it's a spike protein. And again, this is not a political statement. It's a science. It's an oncovirus. It's a cancer-causing virus. It reactivates EBV, another cancer-causing virus. It upregulates genomic pathways that cancer just absolutely loves. It suppresses the immune system, which cancer loves. So I would say it impacts the treatment of all cancer treatments, Maureen. Does it specifically target IPT? I don't know. IPT is different in that it's an immunomodulatory therapy, so it's modulating the immune system. I can tell you what I've seen over the last 3 years is whether it's infection or injection, okay, the cancer changes, and it changes abruptly, and it changes aggressively. I mean, there's many different reasons. It's not just the spike proteins. There's an article talking about the M proteins or membrane protein actually inducing metastasis of breast cancer. So, you know, we're going to look back on history, I think, as we do ADBC, that event, that divided time. I think we're going to look back on cancer and see how it was divided by time by this event of COVID. Had not had any chemotherapy, but has had radiation twice. So I responded to you earlier. Absolutely can. And I mentioned the individual that I talked to actually today virtually. Very similar. But he had prior chemo, a lot of it radiation, and he had metastatic recurrence. I mean, all over the place too, by the way. Not just a little bit, one spot bone here, one spot there. It was all over the place. So we took a completely natural approach, and he has no visible or laboratory evidence of cancer. Let's see. Once the IPT put the cancer in reductive state, I'm now doing a clinical trial with bioidentical peptides where they have done these prior. They've great success with reversing cancer. Marie, I think that's a good point because when you look at cancer, whether we're talking about maximum tolerated dose chemotherapy or low dose metronomic chemotherapy, it's really a spread phase. It's an acute phase of treatment. Though low dose metronomic chemotherapy is much more of a healing process, treatment must reach a point where we transition to healing. That is the ultimate goal. And so there must be a point where we transition to healing. We also use bioidentical, well, we use peptides called, they're custom peptides here. Those are based on proteomic, transcriptomic, and metabolomic testing, and allows us to actually develop peptides, which are short proteins that actually affect change, function, folding, and systemic effects. So it's really much more of a healing shift, but it allows you to be much more targeted. So Marie, that's great. Good luck to you. Squamous cell carcinoma has been metastasized to the lungs. Keytruda, that's an immune checkpoint, has been advised by the oncologist. If coming to your clinic, would you advise starting your alternative therapies, treatments prior to a first dose of Keytruda? Good question. I would say what we do here is not alternative. What we do here is integrative. It's evidence-based. People will call conventional therapy traditional. Traditional is Ayurvedic medicine. Tradition is thousands of years with Ayurvedic medicine. The traditional conventional medicine today is really about 40 years. So integrative medicine is really culminating and accumulating all the different forms of therapies that have existed out throughout history and bringing them together in an evidence-based mode. What I would say when we have widespread cancer, so cancer that is spread broadly, what I presented in this webinar was how combining low-dose metronomic chemotherapy with immune checkpoint inhibitors, of which Keytruda is one, the combination together is synergistic. So what I would say is both. This is a question posted by an anonymous attendee. So I would say both. When I tell people about conventional cancer treatment or conventional treatment as a whole, I'm a conventionally trained doctor. So I don't malign it. I just say sometimes the way it's used, it's not used correctly for the point in time. So if you break a hip, I'm not going to tell you to go take more vitamin D. You need to surgically have it repaired. And here in this particular situation, you have cancer that's spread to the lungs. And Keytruda can help there, but by God, let's help that work better. Let's bring together a sequence and a combination of treatments that give you your best outcome, not just one therapy. Cancer didn't happen because you were missing Keytruda. Likewise, cancer didn't happen because you missed low-dose metronomic chemo with insulin potentiation, to be fair. But we want to bring these together to give the results. We want efficacy. We want good outcomes. Success with prostate cancer? Oh, yeah, a lot. And honestly, preserving function too. A lot of patients come in, it's not a laughing matter, but a lot of patients come in having had prostate cancer treatment, and they may have the prostate cancer resolved for a short time from a conventional cancer treatment, but now they have no sexual performance. But yeah, we've had really good results with prostate cancer. Doesn't matter the stage 1, 2, 3, 4. Do you require biopsy before you accept a person for IPT? Well, we like to know what we're dealing with. Now, if a person has a history of breast cancer, then they have a new area that pops up in the bone. I'm not an advocate of going in and biopsying that because we know what that is. There's no reason to do that. There's other testing that allows us, without invading that space with a needle, to determine what's going on. There's some testing available today where every now and then we have patients that come in with an unknown primary, meaning they've biopsied it, but they cannot figure out where this cancer is originating from because it's kind of all over the place. And it has characteristics that are, not exactly unique and common to many different types of cancer. So we have testing through blood work that would allow us to actually determine with a high index of specificity of what this is. But, we like to know what we're dealing with. So we like to have people have a biopsy one time when they come in, but we like to protect them through that process as well. But if somebody's had a prior biopsy, we know the diagnosis, and it's just shown up at a new site, there's no reason to go in there and poke and prod at that again and stir that all up. Hodgkin's lymphoma diagnosed in February 2020, was treated with BVABD. I felt a lump on my neck, went to my oncologist, they diagnosed it as a relapse. I did only vegetables for 1.5 months. Okay, I guess I'm thinking you did vegetables along with the ABVD chemotherapy full dose. What we want to do in the treatment of cancer is recognize the complexity that it is and really go after it with the full intention to heal the first time. Now, if you don't achieve healing the first time, you can come back a second time, the third time. We just would rather not. I think most patients would raise their hands to that option. But what I tell patients, when you have cancer on the run, when you have your throat on the foot of cancer, it's time to finish it. When you're ahead, when you're winning, you run up the score. So that's what we try to do. And trying to approach cancer, the way conventional treatment tries to approach cancer is very segmental. And you can't do that. You have to approach this simultaneously with a plan based on evidence, with regular evaluation to ensure that what you're doing is actually working. My lymph nodes decrease in size. Could it be wrong diagnosis? No. It's not likely the wrong diagnosis. It's probably that the dietary changes are helping. I mean, nutrition is foundational to what we do here at Brio-Medical. You know, we know that the gut bacteria, the gut microbiome, it's critical to its population is critical to what we eat. And we know that's critical to the systemic immune response. So, what you eat is foundational to treatment. So, no, it could be that your diet has decreased those lymph nodes. What is the acceptance of allopathic? What is the allopathic acceptance of these methodologies? Great question. Well, I didn't really focus here on acceptance or not. What I said is here's the evidence, Jeff. Just simply the evidence. As scientists, that's what doctors are. We should not be into what groupthink is. We should be into what critical think is. That is, okay, here's a question. What does the evidence say about it? And just simply follow that. Not, well, this is what the quote unquote standard of care is. This is what they do. This is what they do. This is what I do. No, it's what does the evidence say to do? And then target that through precision testing. That's the right approach, Jeff. So, um, is there some acceptance within allopathic communities of this? Yes, it's becoming more and more. I mean, IPT basically is a terminology, low dose metronomic chemo with insulin potentiation, that's being hijacked by the term low dose metronomic chemotherapy. It existed long before, 50 years or so before. First case of cancer treated with insulin potentiated low dose chemotherapy was back, I think it was 1947. So, if they're not going to accept it, that's 47, that's 53 years, that's 76 years, 86 years, excuse me. Will they ever accept it? I think that's probably the better question. So I hope everybody's had a great day. I hope this has been helpful, not too deep. Look for this to post tomorrow. I encourage you to read the studies, read the articles. They're deep, but it's important to empower yourself with knowledge, and out of that will come wisdom. So good luck to all of you. Have a great evening, great rest of your week, and to your healing and health. And until next time, I'm Dr. Nathan Goodyear, Medical Director at Brio. Again, check us out at all the social media, Brio-Medical, our website, www.briomedical.com, as well as my personal brand site, website, www.drgoodyear.com, and Practicing with Dr. Nathan Goodyear podcast, wherever you download podcasts. And we look forward to talking to you soon.